of us will be fine. Where do you tilt on this argument? Is the large prevalence of asymptomatic cases a blessing or a curse?
No, you ask a great question, Kojo, and I think every person who is into epidemiology will always be excited with this kind of question. Now, you hit it right on the head because there are pros and cons to having a number of asymptomatic cases. And again, I say a number because we, as of now, cannot reliably determine the proportion of our population that is asymptomatic. Now, it is only when you have an idea of that proportion and are able to measure what the tipping point is that you can say whether it is more of a blessing than a curse or vice versa. There are certainly blessings in that, and there are, disadvantages to that. Now, the way in which you would want to measure your proportion of asymptomatic cases is by, doing what we call a seroprevalence study, and this needs to be done pretty early so that you want to catch people who actually have the virus in them and be able to determine whether they are sick or not. At the same time, also be able to measure those who may not have the virus but have evidence that they have been exposed to it because they have antibodies. And I know that there are a number of people all over the country, and I believe the Ministry of Health, the Ghana Health Service, are actually working towards carrying out some of these studies. Some of us have proposed and are in talks with the Ghana Health Service and the Ministry to conduct these kinds of studies, and the response so far has been very encouraging. They recognize the utility of these kinds of studies, but no one has as yet actually done this. So we do not have a measure of the number or the proportion of asymptomatics. A number of studies have put it in different societies between 30, 50%, some even more than that. So what we should appreciate is that we cannot determine how much of a blessing it is and how much of a disadvantage it is. But as you have rightly said, the advantage is that if there are many of these asymptomatics, then it means that, people are going to have the disease and just be fine without it taking a toll on them and on society. But the disadvantage is that an asymptomatic person can easily spread it or give it to someone who might not have a good outcome. And as of now, it's very difficult to tell those who would have bad outcomes from those who would have good outcomes, except to say we know that diabetics, those with hypertension and underlying chronic diseases are more likely to have bad outcomes. There's all this talk about having a strong immune system, but the research currently is showing us that beyond just having a strong immune system, and I know the President touched on some of the things we can do to have a strong immune system, but beyond really having a strong immune system, it's really about having a balanced immune system, because we argue that if your immune system is actually too strong, whatever that means, because this is not a scientific discussion, if it's too strong, you might actually end up with a reaction that will lead to your death. And having a balanced immune system is really a difficult thing to achieve. It's not necessarily achieved by exercise and by eating well and all these kind of things. It also has some genetic underpinnings to it. But by and large, it does not negate the fact that you need to have a good immune system. And eating well, exercising will help you to have a good immune system. There's nothing that you can do necessarily to have too strong an immune system. So by and large, I would say the advice to eat well, exercise is good, but it's not necessarily a guarantee that you will escape if you should have the virus. We've seen people who are otherwise healthy and strong coming down very badly, and others who've had transplants of kidney, of liver, just coming out unscathed.
I was about to ask, until you clarified, I was about to ask, so is it possible to eat a little too much kontomire, and then that ends up, putting you at a disadvantage and causing you to have too strong an immune system?
No, that's not possible. That's the reason why I said that the advice to eat well, exercise is great advice, but the caveat is that it's not a guarantee. The fact that you have a good immune system is not necessarily a guarantee, because it's really about a balance. And achieving that balance is really not something that you can do by yourself. It's a function of your genetics, but it's certainly important not to have a weak immune system, and you can avoid having a weak immune system by eating well and exercising.
That explains it quite well. Thank you so much. But don't go away, please, Dr. Amwese. I've got a couple more things I want you to explain to us. But joining us on the line is Dr. Titus Beo. He's the Deputy General Secretary and a member of the Infectious Diseases Committee of the Ghana Medical Association. Dr. Beo, thank you very much for your time with us. Good morning.
Good morning, and thank you for having me.
Wonderful. Now, the association issued a press statement before the president's address. You called on the president not to lift the ban. He didn't lift it. Happy?
Certainly. We are happy that he has not lifted it and that the ban is still in force, because we thought it would be a recipe for disaster if it was lifted.
Now, Doc, the thing that occurs to me is that we're not doing very well when it comes to adhering to the safety protocols. We're not doing as well as we could. The mask wearing is shambolic. You see people wearing masks on their chin. People are still, touching, exchanging money, sharing personal space. We're not washing our hands as often as we should. There are several places that don't have facilities for washing hands. Look, some are doing well, but a lot of us are not. So in light of this, ban lifted, ban not lifted, are we still not in a precarious position?
So we are. There are several levels of protection or prevention of this condition. And there is the governmental policy level, such as the locking of the borders or closing of the borders, imposition of these bans. But there is a personal level, which is where we think we are lacking. And I pretty much agree with you. And I think that this ban being enforced helps us to all go out to do a massive campaign for people to really appreciate it. There are people who still do not believe that this disease is real. They don't think it's in this country. There are people in the rural areas who think it's an Accra disease, though it's in almost all our regions now. And there are some who say, I've never even seen a patient with this condition. So how do I even know that it is real? The patient should come out so that they will see them. I mean, these are some of the feedback we are getting. And it tells us that there is a lot of room for improvement as far as public education is concerned. And I think the benchmark to guide whether we will ease this ban should be the level of public awareness and implementation of these personal preventive measures. To the extent that we are not satisfied, all of us are not content with how people are behaving, then lifting the ban would then worsen our situation. You can imagine if we are allowed to gather and people do not believe that this is real, people do not wash their hands, people still cough in the open without any covering, then it will just get terrible.
Dr. Beo, I want to ask you a provocative question. We were talking a little bit about it earlier. But, so, look, at some point, these restrictions will have to be lifted. That is just the reality of life. Bearing in mind that while the restrictions are in place, you confirm, just as I said, that we're not doing as well as we could. And infections are growing. People are continuing to get infected. One person infected 533. And it goes on. However, we tend to be largely asymptomatic. Is there not an argument for, of all the countries, Ghana attempting what they call herd immunity, simply letting us go about our business? There will be infection, but largely it will be asymptomatic. Is that not perhaps a better, more effective, and at least better for the economy way of dealing with this, bearing in mind that we are not really adhering to the restrictions?
I think that is a very, 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 very dangerous way of looking at it. And I think we did emphasize that even in our statement. Any attempt at herd immunity will be catastrophic. We are happy that we are having a lot of asymptomatic. We are happy that our mortality rate appears low. This virus is novel, and we do not know how it's going to change with time. But so far, the data available to us, and we have also seen it in this country, that they are at risk population that when they get the virus, they succumb. Now, we do not know the burden of this at-risk population in our society. There are several populations. One is that the active people who are not sick, who are strong, who are healthy, are the ones moving about, and they are the ones who are contracting the virus now. If we give ourselves time, the virus will shift into the proper at-risk population, where these healthy asymptomatic people will spread this virus to the elderly, the sick, and that's why we are so careful about outbreaks in hospitals. So you can imagine people who are already going through dialysis, people who are not well, who are coming to hospital for various conditions. If you have a mass outbreak in the hospital ward, touch wood, what happened in that factory? If it had happened in a hospital, we can count the number of fatalities that will be coming. Most of these factory workers are healthy people who are moving up and down. And so most likely they will all survive it and may not show any symptoms. So any attempt at herd immunity will come at a cost we may not be willing to bear. So I think we should not even think about it at all.
Okay.
We should try our best to stay the course, to try to manage the few who show symptoms, and get those who are asymptomatic to know their status and try and change their lifestyle so that they do not carry to those who are at risk. I think that is the best approach that would help us as a nation.
Right. Stay with us, Dr. Beo. Let me bring back Dr. Amwesi into the conversation. And Doc, the other thing is our recovery rate. That's another thing that sets Ghana apart from the rest of the world. So as I calculate it right now, our recovery rate is something less than 10%. However, around the world, the recovery rate is way above 25%. In fact, out of the 4-point-something million people infected around the world, about 1.5% of them, 1.5 million of them, have recovered. So, yes, a good, healthy 25% and over global recovery rate. But in Ghana, it's less than 10%. What's that about?
Hi, Kojo. Can you hear me?
Yes, we can hear you.
Great. No, so I think that's also another great question, and I really also appreciate the contributions from Titus. I couldn't agree with him more. But really, to the question on the recovery rate, we need to put this in context. And just like I was urging us to put the numbers of cases in context, as well as our attempts at showing where we are also in context, the same goes with the recovery rates. Our focus for now, as far as I understand, has been on, tracing or tracking, testing, and then treating. So the resources that are available currently for testing have been focused on people who are suspected to have been exposed or suspected to have the disease. To really certify somebody as being disease-free, you need to conduct a number of tests over a period of time and be able to establish that the virus is no longer present in the person to say they have recovered. If you're not doing this, you cannot just assume that because somebody was tested and was positive 3 weeks ago and they have not yet been tested again, but they appear fine, you cannot just conclude that they have recovered, all right? So just like we are not actively measuring our rate of spread, and I've always maintained that we have not measured our rate of spread, and therefore it's very difficult for us to make projections. It's exactly in the same way we have not systematically measured our rate of recovery. If we were to do back-of-the-envelope calculations, one could easily argue that if someone was tested positive and after 2.5 weeks they are fine, the probability is that they have recovered. This is about 98% probability is that they have recovered. But you cannot rush to these conclusions until you've actually tested them and found them to be virus-free. So I would say, to be honest, we should not really worry about our recovery rate because, again, we are not measuring that actively enough. I would say that giving our limited resources, our focus really should be at this stage, now that we have, focused on, tracing, tracking, testing, treating those who we know are suspected. We should move to those, to the mass level of testing and even not worry so much about our recovery rate, because because that also requires resources that we do not have. So, looking at the recovery rate that we have, juxtaposing that against the global one, you may say it is low, but to give a fairer estimate, I'll say we should look at the proportion of those who are positive who have, moderate to severe illness. That would be a better proxy with which to compare with the global figures.
Right. Now, so to clarify, the president used the term aggressive testing. He says we are doing aggressive testing. But I listened to you, Dr. Amosi, on Newsfile, and I heard you explain that the testing we're doing so far and the numbers that have come out of it are simply from the enhanced contact tracing. That's basically the bulk of what we're doing, and so our numbers reflect that. And that the sort of the routine surveillance and so forth, people just randomly walking up to a hospital or calling a hospital and saying, reporting symptoms, that still is not the focus of what we've been doing, which means we don't have a clear picture of the spread, particularly the community spread. But the president says aggressive testing. We're doing aggressive testing. Is he misstating the situation?
Again, just like I said on Newsfile, I understand aggressive testing to mean aggressive testing of people who are suspected cases or people who we suspect have been exposed. But what one would expect the testing to be would be at the mass level. So you have a number of tests that you are conducting, a minimum number on a daily basis within the general population, within urban areas, within rural areas, and you do this at a regular rate. When you do this, you can have a fair measure of the number of positives you're picking up on a daily basis, and then from there you can go ahead and measure your rate of spread. So if you want me to comment on aggressive testing, I get the impression that it's aggressive testing of suspected cases and exposed persons, but I certainly do not want to think it's aggressive testing of the population, because we're not doing that right now, and I think that is what we should be doing within the next week or so. I cannot tell, again, as I mentioned on Saturday, whether we have the manpower and the resources to do that just yet, but it doesn't change the fact that that is what we need to be doing. Otherwise, we will find ourselves playing catch-up very soon, and that wouldn't be very good.
Dr. Amosi, thanks for that. Let me bring in Dr. Bayo for a final question. Dr. Bayo, this is what the Ghana Health Service is reporting on their website. They have these two tables where they've listed all the number of tests they've done from the different sources: routine surveillance, contact tracing, and mandatory quarantine. Now, it appears that the positivity rate for routine surveillance is 3.46%, while the positivity rate for contact tracing is 2.70%. So basically, out of all the people who have been, every 100 people tested through routine surveillance, 3.46% of them are positive, and out of every 100 people tested through contact tracing, enhanced contact tracing, 2.7% are positive. So the positivity rate is higher for routine surveillance, which translates, according to Kwame Sapon-Asiedu, who has also been looking at these numbers, it translates into the fact that you are more likely to get infected just by walking around than you are to be infected by coming in contact with an infected person. How should our strategy as a nation be adjusted to deal with that reality?
Okay, so I agree. That's another way to look at that data. But the other way to look at it is that routine surveillance in our clinical setting is that...
Dr. Amosi, can I ask you to lower your radio a bit? I think we're getting a bit of feedback. Sorry, Dr. Bayo, actually. Dr. Bayo, I think it's your radio.
Oh, really? Is it better?
If you can lower it entirely. And then...
It's my radio is off.
Oh, perfect. Okay. We should be fine. Please go ahead.
Okay. So I'm saying that there is that's one way of looking at the data. But if you look at the contact tracing and then routine surveillance would mean that these are people who either may have a symptom or we have suspected, or the person has come to hospital with something else and we say, let's check. So it is expected that that population will have a higher positivity rate because they may have a symptom or something that has alerted the health system to want to check them. That's how that data comes about. While contact tracing, you have just had a contact with an infected person and therefore you are being asked to be checked. Now, that contact, the duration of the contact, quality of the contact matters. And so generally, it is expected that the prevalence in that group will be low because, for instance, even in the health system, if you meet a patient for less than 15 minutes and you have contact with that person, the person infected, the probability of you getting infected is very low. So I'm not surprised at that data. So if it comes to how should we adopt our lives based on this kind of data, I think that we should just assume that almost everybody around is infected. Reason is a lot of the people who have it are asymptomatic. It is possible the taxi driver who is driving you now to the market or to town has it. It is possible the barber you go to for a cut has it. And therefore, how do you protect yourself? This is where the personal protective measures that have been mentioned comes in. The enhanced using of the mask. If you are wearing your mask and ensure that the next person offering service to you is also wearing their mask, then even if they have it, the risk of them giving it to you is lower. So I think we have to enforce that. But if you permit me, I just want to make a little statement on the recovery rate,
right,
which you asked my senior colleague, Dr. Musi.
Sure.
Now, on the recovery rate, I think we are too concerned about the numbers, but worried, and the media is talking a lot about the fact that the recovery rate is low, but we shouldn't be too worried. The truth is, we are in the clinical setting and we know what is on the ground. Our members are those working on these patients. Fact is that there are people, how they were tested. Some of them, they cannot even find them to do the second test for us to know if they have recovered. Some of the people who were tested and are in their homes were being home managed. I think the Director General intimated it during the press briefing. That some of them, it's difficult to trace them. Now, if people are asymptomatic, they have not shown any symptom, you test them through routine surveillance or contact tracing and tell them their results is ready 3 weeks later. The person has not shown any symptom. If you move that person into isolation, they will resist it because they haven't seen anything. They don't even believe that they are sick. Getting these people to test again becomes a challenge. The second thing is our country started with a very high bar standard of recovery, which is that you must have a double negative. I don't want us to lower that bar just because we want to increase recovery rate. Because of this talk of low recovery rate, some people are suggesting we should test only once, and then if they are negative, declare them recovered. That is dangerous, and I think we shouldn't go in that direction because from the isolation centers, some people have tested negative once, and then their second test, they tested positive. And they had to wait till they get a second negative before they are declared recovered. What we do not know is that during the second time that they've tested positive, do they maintain the capacity to infect other people? So if we lower the bar to only one test, we will declare people negative who may still be positive. And then they retain the probability to infect people in their community. Even now that we have maintained this very high standard, people are finding it difficult to accept people back into the community after they have recovered for fear that they will share the virus. And we know that those people do not retain any ability to share the virus. We should maintain the bar, increase our campaign, let people know that a lot of our people who are asymptomatic will recover without any intervention. But we should not be worried that the recovery rate in terms of the statistics looks low. It's only because of the bar we have set. And sometimes we are not getting the people to even test to show that they have recovered. Once we get all these, our numbers will come up.
Dr. Titus Bayo, Deputy General Secretary and member of the Infectious Disease Committee of the Ghana Medical Association. Thank you very much for your time. Also a big thank you to Dr. John Amwesi, lecturer, Global Health Department of the School of Public Health, KNUST. Also the leader of the Global Health and Infectious Diseases Research Group at the Kumasi Center for Collaborative Research in Tropical Medicine. Thank you both ever so much for your time. As always, so enlightening. Okay, Winston.
Yes, Kojo. So it means that we're doing a lot of contact tracing, which is not bad. It's a lot of our hands testing. But, I'm just looking at what the president said, Kojo. If you look at one point, he says, and again, let me reiterate, something just caught my mind.
Right.
That these 921 cases were from backlogs dating as far back as 26th April and not necessarily over a 24-hour period.
Which numbers are these?
921.
The ones that he broke into Friday, Saturday, Sunday.
No, there's another one. So if you look at it carefully, the president says that, he talks about the one that one person infected 533 people. Because,
oh, yes. Okay.
Then
so the announcement on Saturday.
Yes, on Saturday.
Yes. Okay.
Good. So when the president talked about that, there's another thing that I saw. He says on Thursday, 7th May, 14,046 more tests were conducted, and this included the clearing of backlogs. Now, the president talks about some of these backlogs dating as far back as 26th April.
Yeah.
Now, I just took a look at the Ghana Health Service when they actually came to us, telling us why they felt we had peaked. The graph that they presented to us has dates that samples were taken.
Yes.
And that graph has results from the 25th, 26th, and 27th.
Yes.
So, at what point were all these samples taken? Now that the president tells us some of the backlog is from the 26th of April, were those actually part of the data that the Ghana Health Service presented to us?
They can't have been because the results hadn't come by then.
Thank you. So if they were not part of the data that was presented to us, how did the Ghana Health Service come by the data they presented to us, indicating, so far as they were concerned, that they actually had data up to the 3rd of May, when we still had backlog?
Yes, and they insisted that the peak was the 25th. Of April. When they hadn't had all the results for 26th and days after that.
Exactly. So there's, a lot more questions we need to be giving answers to. And I've been telling Sami that we should get the Ghana Health Service to actually help us understand this. Because on the 26th of April, according to the Ghana Health Service's own figures, we're hovering around 150 to 160, infections for the day. So I am confused, and I can understand your confusion also. The Ghana Health Service will need to help us understand all of these.
Okay, I want to give you guys homework. All right, I'm still in the Bob Marley mood. I told you how Bob Marley has a song for every occasion, every discussion. There's a song that works with it. I'm going to play the song that I think works with this conversation, because you see, the thing about data is that one little deviation can throw out every single assumption you've made. Okay, it takes just one drop, doesn't it, to change the quality of what you are assessing. And Bob Marley has a song for that. But here's your homework. While we're doing this, I want you to just go to Google. The test that we've been doing is called a PCR test. That's how we've been testing and finding people positive. I want us to go and find the fail rate for PCR tests. Just do that. We'll be back.